So I'm going to talk about implications of COVID-19 for mental health, findings from the longitudinal health and well-being COVID-19 national core study and the convalescence long COVID study. This is, of course, based on a really substantial collaboration, and is the joint work of the authors listed here, including Anne. I'm just presenting it. So, and I should have started by thanking the authors for inviting me to fill the late career researcher slot, which is, of course, unfortunately late. The work's been funded by these two major pieces of COVID funding. So Patrick Vallance established 6 national core studies in sort of summer of 2020. One of which is the longitudinal health and well-being national core study, and it combined data on 20 longitudinal population studies in one aspect of its work, did substantial work on these new trusted research environments, linked data on electronic health records, and there's also a deep phenotyping study as part of convalescence, which was separately funded by NIHR and UKRI to look at long COVID, and it involves all the institutions shown at the bottom here, as well as all these different longitudinal population studies. The work has actually been done by the analyst team shown here. I don't know why I'm on that picture, because although I used to know how to code, I don't actually do that anymore. At least I did a bit in 2020, which was really fun, but not so much these days. But one of the ways in which the COVID, at least for me, and I guess for many of you, has changed things is that this team is a bunch of people employed by the University of Bristol, some of them employed by the University of Cambridge, Angela Wood, Geneviève Césard, and then 2 people who were seconded by UKRI for the national core study. That's Lucy Teese from the University of Leicester and Yinghui Wei from the University of Plymouth. And of course, we've worked as a team completely seamlessly with a Tuesday lunchtime meeting and a Thursday morning meeting, and geography really has ceased to matter, particularly when you're accessing trusted research environments, the essence of which is to bring the researchers to the data rather than sending out potentially disclosive data all over the place. So these analyses have used Open Safely, which was mentioned earlier on by Kathy, and in principle provides secure access to primary care records on up to 58 million people in England, whose general practices use either TPP software or EMIS software. Most Open Safely analyses have used Open Safely TPP, which is and that's what we've used for the analyses I'm about to show you. And that is about 40% of the population in England, about 24 million people. And the way that Open Safely was designed is that it runs inside the cloud data storage for these 2 primary care software providers. So the other data, including SUS, secondary use statistics, hospital admissions, and COVID-19 vaccinations, and SGSS COVID-19 testing data, were all linked within the TPP and EMIS data sets. Now, this isn't a talk about Open Safely, but I'll just briefly say that the principle of it is that the researcher never sees the raw data. So you specify your question, and on the basis of your question and what data you say you want, you're provided with synthetic data, and you work up your code using synthetic data. And when your code works using the synthetic data, you then send it off to the real data. You can't line list it or see anything, and then you get your output back from the real data. Of course, in practice, and my colleagues will tell you, the code doesn't work against the real data because the synthetic data can't replicate the complexity of the real data, so it takes a long time to get the thing working. But the idea is that you then get outputs back, and then you can't release those outputs until they are checked by somebody independent. And it's all built around using GitHub, enforcing code review, making sure that all code lists that are used are shared. They're all available in, you can see what jobs are running against the raw data right now. If you go to jobs.opensafely.org, although you shouldn't, because you should listen to my interesting talk, you can see the code lists at open code lists and so on. So our research question here was, does the incidence of mental health disorders after diagnosis of COVID-19 differ from the incidence before COVID-19 or in people not diagnosed with COVID-19? So the basic cohort design is that we split follow-up for people who didn't ever get diagnosed with COVID-19. They're the comparator group. But in addition, we split follow-up for people who were diagnosed with COVID-19 into time before and after that diagnosis. So it's with COVID-19 compared to before or without COVID-19. We followed people from the beginning of the pandemic in January 2020. We adjusted for a wide range of potential confounders, which of course you can do using these very detailed linked data. And they included age, sex, region, and a whole set of disease diagnoses in the past medical record. And we did separate comparisons following hospitalization for COVID-19 and following COVID-19 that didn't lead to hospitalization. Now, our analyses were done using 3 different cohorts, which we'll refer to as the pre-vaccination cohort and the unvaccinated cohort and the vaccinated cohort. Pre-vaccination cohort was followed from the beginning of the pandemic until the rollout of vaccination in your particular age group. So at the point when you became eligible for vaccination, follow-up stopped. And of course, that is mainly during the wild type era. In black, you can see the initial, of course, the number of cases in many cases of COVID weren't diagnosed in the first period because of limitations on testing. And then we can see the second wave. And then in blue, the advent of the Alpha variant and the start of the rollout of vaccination. And then in red, the advent of the Delta variant during the second half of 2021. And so the vaccinated cohort are followed from 2 weeks after their second vaccination. And the unvaccinated cohort are followed, I think it's from the date 2 weeks after they were eligible for their second vaccination, but did not receive second vaccination. So we've tried to make them comparable, although of course, well, I'll show you in a moment that they're not comparable because the sort of people who get vaccinated differ from the sort of people who don't. Okay, so 3 cohorts. The numbers vary, but basically the pre-vaccination cohort is about 80 million adults, and then the vaccinated cohort is about 13.5 million adults, the unvaccinated about 3 million adults. Obviously, the pre-vaccination cohort represents the population, so half of them are male, 35% aged 80 to 40, 22% non-white minority, 20% living in the 20% most deprived areas. The vaccinated cohort, unsurprisingly, is slightly less likely to be male, more likely to be older, less likely to be non-white, less likely to live in a deprived area, and of course the characteristics of the unvaccinated cohort are the opposite of that, and are, as you'd expect, more likely to be male, because males are not very sensible about their health, more likely to be young. Young people are actually quite rational in being less likely to be vaccinated because they were less at risk, more likely to be non-white, from a non-white minority, more likely to be living in a deprived area. And then about 1.15 million COVID diagnoses in the pre-vaccination cohort, 800 and something thousand in the vaccinated, and 162,000 in the unvaccinated. And I just been told I've only got 5 minutes left. I only feel like I've just got going. But here are the numbers of events. And just to show you that we're, so you can see, none of you will be surprised by these numbers, but about 1.2 million diagnoses of depression in the pre-vaccination cohort without COVID-19. And then in that cohort, about 6,000 after hospitalized 19 and about 43,000 after non-hospitalized COVID-19. And then the numbers in the other two cohorts broadly reflect both the incidence of COVID-19 during their shorter periods of follow-up and the proportions hospitalized and non-hospitalized. We're also going to look at serious mental illness, which is a composite of schizophrenia, bipolar depression, and other psychotic depression. Thank you, Anne. I noticed you commented on that in the draft paper. And so we've got about 364,000 diagnoses of serious mental illness in the pre-vaccination cohort in people who didn't get COVID-19, 1,500 after hospitalized COVID-19, about 13,000 after non-hospitalized COVID-19. Okay, now Kathy showed you one of these plots before, and let me quickly take you through it. So firstly, the sort of gold lines are for the pre-vaccination cohort, the green are the vaccinated, and the blue are the unvaccinated. We've split follow-up after COVID, the references before COVID-19 or without COVID-19. We've split follow-up into 0 to 4 weeks after COVID-19, and then 4 to 16 weeks after COVID-19. And then only in the pre-vaccination cohort, we've got longer follow-up up to about 18 months after COVID-19. There are our 8 outcomes, and you can see that in the pre-vaccination cohort, uniformly, there's a substantially elevated incidence of these different mental illnesses in the first few weeks after COVID-19. For addiction and eating disorders and PTSD, that broadly goes to hazard ratios of about 1 in the extended follow-up in the pre-vaccination cohort. For the other outcomes, there's a continued small elevated incidence of COVID-19. And then you can see that the elevation in incidence was highest in the pre-vaccination cohort, intermediate in the unvaccinated people, and lowest in the vaccinated people, which is what it says there. Okay, now for depression and for serious mental illness, thank you, you are really strict. For depression and for serious mental illness, we've also got the outcomes split into all on the left, that's actually the same as what I just showed you, and then after hospitalized COVID-19 with the smaller numbers of events, and after non-hospitalized COVID-19 with a larger number of events. And you can see that the elevation in incidence is higher after hospitalized than after non-hospitalized COVID-19. And the vaccinated and unvaccinated cohorts actually look more similar when you stratify according to how severe was the COVID. So the benefit of vaccination is in reducing the severity of COVID-19, which reduces the implications of COVID-19 for subsequent mental incidents of depression and serious mental illness. And you can see that the persistence in elevated risk is higher for longer after hospitalized than after non-hospitalized COVID-19. And just to give you an idea of overall, we're talking about a hazard ratio of 1.17 in the second year of follow-up for depression and 1.13 in the second year of follow-up for serious mental illness. And I will say that you can't rule out confounding being the explanation for some or all of that small excess. So there's an elevated incidence of diagnosis of mental health disorders in the first 4 weeks after COVID-19 across all of these mental health disorders. More than 4 weeks after diagnosis, the incidence of eating disorders, PTSD, and actually addiction is similar to the incidence before or without COVID-19. In the pre-vaccination cohort, mainly diagnosed with COVID-19 during 2020, The incidence of depression, anxiety, self-harm, serious mental illness, and suicide was higher for up to 18 months after a diagnosis of COVID-19. That elevation in incidence after COVID-19 was more marked in people of serious mental ill health, not COVID-19, was more marked in people who were diagnosed during 2020 and who were not vaccinated before diagnosis of COVID-19 in the Delta era during 2021. The elevation in incidence was more marked after COVID-19 that led to hospitalization than COVID-19 that didn't. And I didn't have time, you'll be glad to hear, to show you this. But of course, with these very large numbers, we can do subgroup analyses by age, by gender, by prior history of COVID-19. And that elevation in incidence was more marked in people with no prior history of the corresponding mental illness, who are older, who are male, or who had had COVID-19 before for the 2021 cohorts. Thank you very much. Any questions?
Are there any questions? Rudolph? I'll start.
I was wondering, we hinted at this. Thank you. Is it possible to estimate how much might be due to the fact that COVID takes you to your doctor? So, and then they pick up other things, because the hospitalization data and the fact that you get addictions elevated just after you're diagnosed with COVID, you sort of think that's not an obvious thing where you get COVID and then get on the booze or something. So I was wondering whether that's a sort of potential confound for some of it.
That's a really good question. Thank you. A lot of the events that occur in the first 4 weeks are recorded on the day of diagnosis. Although I don't have that particular table with me for these particular analyses, but we put that in the supplementary material when we write these papers. Now, as you say, people are showing up with COVID-19 and they're having a diagnosis of COVID-19 recorded and a diagnosis of other things recorded. That could be, for example, that somebody showed up with a mental health crisis and then just by coincidence had COVID-19. So that probably explains some of that short-term elevated incidence. I don't think it explains all of it, because the elevation in incidence is very specific to different conditions. So for example, for pulmonary embolism, you get incredibly high hazard ratios in the first period in the first day, well, on the day and afterwards. And it's much higher than for other things because COVID causes PE. So it's not all of it. It may be some of it, and some of it we cannot disentangle because it's recorded on the same day.
Go ahead.
Hi, I with my colleagues did a very similar analysis of this. We examined using primary care data sets, looking at incidence of anxiety, depression, psychosis, antipsychotic prescription, anxiolytic prescription, antidepressant prescription. Did we do, anyone remember? Don't know. We did lots of things, and fatigue. And it's just an idea, don't have to. But what we did, if you've got COVID test information, you could also look at the cohort of people who tested negative for COVID, which might account for some of that, who presented to services and tested negative. And that might, and see if you're seeing similar elevated levels in those people who had a test, were given a result, who were in presenting, but who didn't actually have a positive infection. We did that, and you will see that some of these are sustained, some remain, and some will look less conclusive.
So that design, that test negative design, has been used extensively, particularly to look at effects of vaccinations, as I'm sure you know. And it is an alternative design. It's got potential, well, the biggest potential advantage is that you hope that the sort of people get tested are more similar to each other. So you hope that you're dealing with a lot of the confounding. So I agree, it's an alternative design. There are also potential disadvantages of that design. So hopefully these are just complementary contributions to the literature. Hopefully, I think that the long-term follow-up might, well, it's certainly harder to do a test negative design. The test negative design now that routine testing isn't really happening. There are interesting methodological discussions about the potential biases in test negative. The potential bias here is potential unmeasured confounding.
I think it possibly the benefit of this is triangulation of different methodologies, which strengthens the findings of each other's results.
Indeed.
Yeah.
Exactly, and it's the way to take that tricky question forward, is to approach it in different ways rather than relying on, oh, well, we're doing it in a bigger data set.
Yeah, I agree.
One last question there, and then hopefully Bruce will be happy with me. And we can make that really quick.
Hi there, Liz Ford from Brighton and Sussex Medical School. So in this data, which is GP records, you're relying on what the GP decided to code. So I just wondered what you think about the idea that during 2020, given that your study was also looking at long COVID, some of the coding for anxiety and depression might have been GPs' prejudices against recording something like long COVID or other somaticizing disorders. I don't, and whether as GPs kind of, well, the story of long COVID became, codes appeared and things like that, whether that may have changed over time.
So the story of long COVID coding is a really interesting one, because those codes were really badly underused. In fact, there's a very nice open safely paper showing, we've got good estimates for the number of people with long COVID, and it's certainly many hundreds of thousands. And I think it was 36,000 long COVID codes were used in diagnoses made by GPs following the introduction of those codes in late 2020. So it's certainly possible that, well, it's between possible, plausible, and likely that people who were suffering long-term effects of COVID-19 became depressed, and therefore got. I think that part of it is entirely plausible. I think it'd be very tough to disentangle how much of the elevation in incidence we see here is because of that. Although, I mean, the encouraging news is that there's the elevations in incidence by the time you get to the second year, even in the people in 2020, become quite modest.
So a colleague, Anup Shah at UCL, has got the free text in Thin to examine the symptoms. So
Indeed.
He's put that in a preprint, so it's worth looking at.
Thank you so much, Jonathan.
My pleasure.
I guess one of the things that hasn't come up, but will be interesting to talk about at another time, is one of the big challenges here that I think sort of didn't come across is this is like, it was pipeline analytics, wasn't it? It was the same analysis across lots of different disease domains, which led to lots of conversations, didn't it?
Similar analyses, but then with particular differences, because when we talk with clinical experts in particular area, they say, oh, in this particular condition, we need to do this. We need to rethink the list of confounders. But yeah, it certainly has taken, it's taken a long time to do these analyses, just because it is really challenging to do analyses in these amazing, fantastic new analytic resources. That's the two sides of it. You're nodding, yeah. And so, on the one hand, it is just brilliant that we've got these new resources, and we need to sustain them beyond COVID, and they are, I think, being sustained beyond COVID. On the other hand, it's not the same thing as logging onto your laptop and running a few analyses. I mean, there's a substantial technical additional hurdles to go through.
I just thought it was useful to get that across, isn't it? There's huge advantages, but it's not as easy as it sounds when you're putting up pictures of UK level data. And then I guess the other thing is that lots of these are using SNOMED coding, these environments. And we were working very quickly and we amalgamated across lots of different universities, different code lists, but I don't think we're there yet. I think there's lots of work to be done on SNOMED coding in mental health. And I know I've been talking to Katrina about it in the break.
But one of the fantastic innovations in Open Safely is that whenever you develop a code list, you automatically post it and make it available. And, you know, why was that not done all over the place 20 years ago? I mean,
there is the phenotype library in HDR UK.
Yeah.
So part of some of the funding that we have through another avenue is to do that work. So I guess it's all watch this space.
Indeed.
So thank you very much,
My
Jonathan.
pleasure.